terms of how we evaluate patients with pulmonary hypertension and in terms of the diagnostic workup. And particularly, I will focus on attention on the role of echocardiography and what we do in the cath lab in terms of how we make the diagnosis, because a wrong diagnosis can have significant consequence in terms of either way, in terms of calling someone pulmonary hypertension and subjecting them to a form of therapy, or not making the right diagnosis and not calling them pulmonary hypertension that requires the therapy, and then, expose them to a situation where they do not have therapy for an appropriate condition. So we're going to go through this fairly quickly. I have quite a number of slides, but I will slow down on areas that I think require attention. Generally, the topic is pulmonary hypertension. It's not pulmonary arterial hypertension. And I'm going to differentiate that as we go along. So normal pulmonary artery pressure is usually about less than 15 millimeters of mercury in the pulmonary circulation. When it is abnormal, we have a mean PA pressure or pulmonary arterial pressure of greater than 25. At rest or with exercise, it goes higher to 30. This correlates with peak systolic pressure. So when we read echoes, sometimes, and we say someone has a pulmonary arterial peak systolic pressure of 40, that correlates with a mean arterial pressure of 25. This is the clinical classification of pulmonary hypertension based on the WHO recommendation, but this is the ACC, American College of Cardiology Foundation, and the AHA guidelines, and they're all uniform in terms of how they define pulmonary hypertension. As you can see, group 1 is pulmonary arterial hypertension. It's just one form of pulmonary hypertension, and it is about 30 to 50 per million. It's a fairly rare disease, but it's uniformly fatal if the appropriate treatment is not instituted in a timely fashion. But it is not common. It is a rare condition. And it used to be, the series of conditions listed there, it used to be the so-called idiopathic pulmonary hypertension that we're all familiar with, and other considerations that are grouped under the group 1 includes familial pulmonary hypertension, which has some genetic underpinnings in terms of the bone morphogenic protein receptor abnormality in the gene, and some single nucleotide polymorphisms are associated with the familial type. Then pulmonary arterial hypertension that is associated with a whole host of clinical conditions, particularly connective tissue disorder, HIV, congenital shunt, drugs and toxins. So these all lead to pulmonary arterial hypertension. The group 2 is pulmonary hypertension that is due to left heart disease. This happens to be the bulk of the pulmonary hypertension that we see. So some people have used terminology as pulmonary venous hypertension, but you will see as we go over this topic that it is not always the case, because the hemodynamic classification, as you would see, sometimes can give you a mixed picture where you can have pulmonary venous hypertension over time translating into a pulmonary arterial hypertension, or a mixed picture. So that's quite a common classification, a common group. Group 3 is pulmonary hypertension that is related to lung disease. And you can see the list of the lung disorders in there. And then group 4 is pulmonary hypertension due to chronic thromboembolic disease, venous thromboembolic phenomenon. We had a patient the other day that I was asked to see, that 18-year-old young man with recurrent PE and severe pulmonary hypertension. Dr. Harris was kind enough to allow us use our connections, and the patient was transferred to Alabama, the University of Alabama, for evaluation. And in this kind of patients, ultimately, they're going to require surgery, a pulmonary endarterectomy, in order for you to effectively treat them. Of course, you're going to do that's a definitive treatment, but you're going to do the other palliative care like anticoagulation and all that. And group 5 is the miscellaneous. This is kind of a mixed bag of people who don't fit into the other classes. So this is the general classification that is used across the board, across different disciplines, including World Health Organization. There is another way of classifying these patients. You might come across this as you read on this topic, which is pre-capillary and post-capillary pulmonary hypertension. And you can see how you can fit the first classification I gave you into the different groups. So for pre-capillary, that's before the venous system, you can have a whole list of conditions listed there in terms of group 1, group 3, and group 4. They can all fit into the pre-capillary diagnosis in terms of this classification. In this instance, they all have an increase in pulmonary vascular resistance. And the post-capillary are typically and largely patients with left heart disease. And then you have the mixed picture. We'll talk about that a little bit more. But it's predominantly left heart disease progressing into a mixed picture. So this is what I was alluding to. Now I need to so this is what I was alluding to about pulmonary venous hypertension progressing into pulmonary arterial hypertension. So as you can see, PV hypertension here, what you see hemodynamically when we do a right heart cath that is done appropriately, you see there is increase in pulmonary arterial systolic pressure, but the vascular resistance is normal. As time goes on, you can have a reactive pulmonary arterial hypertension where the hemodynamics, when you cath the patient, would show an increase in PASP, pulmonary arterial systolic pressure, with a reversible increase in pulmonary vascular resistance. Reversible in the sense that as you optimize therapy and you go back and you repeat the right heart cath, you might find that the pulmonary vascular resistance has now normalized. And then when you have progression of disease with time, with a chronic remodeling of the pulmonary vascular bed, you're going to have a fixed increase in pulmonary vascular resistance. So a left heart disease that is unmanaged, not treated appropriately over time, can eventually get you into a pulmonary arterial hypertension, kind of a mixed picture. When we do the hemodynamics in the cath lab, it is important for us to realize that as you make certain calculations in the lab, this is the calculation for the PVR, that's the pulmonary vascular resistance in Wood units. You tend to use certain numbers to derive that. And it is important to underscore that as you create errors in terms of how you derive your numbers in the cath lab, you can also create errors in the final number and misclassify a patient in terms of where they belong and potentially deny them or commit them to therapy that is not required. So the way we calculate this is that we take the mean pulmonary arterial pressure, we subtract the mean pulmonary wedge pressure. This is classically the transpulmonary gradient, and you divide that by the cardiac output. Now the cardiac output can be quite a potential for error, because in a patient with severe left ventricular systolic dysfunction, you cannot rely on the hemodilution methodology. It's less accurate in those patients compared to the FIC method. So often in the cath lab, when I do these cases, I use both methodology in terms of calculating my cardiac output. because you can then review the numbers and make some sense. We don't just get hemodynamics and pour it out. The hemodynamics have to make clinical sense. So there's a potential that you can make an error in this number and therefore make an error there. So you've got to be careful in terms of how you arrive at the final number, because this is a very critical number in terms of saying whether you're dealing with pulmonary arterial hypertension or whether you're just dealing with regular pulmonary hypertension. The role of right heart catheterization is the gold standard for you to make a diagnosis. That's your PA catheter going through the right atrium, the right ventricle, and up into the pulmonary artery. Where you put your catheter to get your wedge is important. You don't just throw these numbers. There are times you have to stay in the cath lab to make sure you get to the right wedge. And we define, you want to get into the zone 3 in terms of where you put, where you want to get your wedge. The optimal wedge will be in the zone 3 area, where you have an open conduit between the pulmonary artery and the pulmonary vein. This is where the alveolar pressure is not compressing the veins or the vessels, so that you do not have an occlusion and falsely elevated pulmonary wedge pressure. So you want an open conduit, and it is in the zone 3 area that you will get that. And that's usually right in the, just below the right mainstem bronchus. Now, when we wedge, we also do saturation at the wedge pressure. We obtain an arterial saturation, because in a wedged position, the arterial saturation should be equivalent to the systemic arterial saturation. If they are not equal or very close, then you know you are in the wrong wedge position. So you will have to take out, start searching for the appropriate wedge position. So right heart catheterization is important, and these are the hemodynamic waveforms as you get to your wedge position. So we've talked about the clinical definitions. Now we want to look at the hemodynamic definitions based on what we obtained during the catheterization. In PAH, perhaps the most important number you want to know in PAH, as you would see, will be the pulmonary vascular resistance. But in PAH, in PVH, and in mixed, the PA systolic pressure is always greater. We use 35 here, but it could be 40. The mean pulmonary arterial pressure is always greater than 25. That is the definition of pulmonary arterial hypertension. So in all 3 scenarios, they all have those numbers. However, the difference is you start seeing in the last 2 scenarios. For you to have a diagnosis hemodynamically of PAH, the wedge pressure must be less than 15. That is a normal wedge pressure. The patient must have a normal wedge pressure, and the pulmonary vascular resistance should be greater than 3 Wood units. So the key is that you eliminate any potential that what you're seeing here is due to any left side disorder or disease, in which case the wedge is going to be higher than 15. And that's what you see here. So in pulmonary venous hypertension or pulmonary hypertension due to left heart disease, the wedge is always high. Even though these numbers are similar, you see the wedge is high. And in the reactive type, the resistance is typically low. So this will be a typical pulmonary venous hypertension. And then in the mixed picture, where you may have reached a position where the pulmonary vascular resistance is now fixed, this number is now similar to what you have in PAH. So the mixed picture is similar. So this is the hemodynamic breakdown based on CAD. So let's go a little bit. We talked about this as at the beginning of the presentation, but it's helpful to point out that PAH shares in group 1, these conditions, they share a similar clinical presentation and a similar histopathology in terms of what occurs in the vascular bed in terms of the remodeling process that occurs in the pulmonary arterial bed. And then the response to pulmonary vascular targeted therapy is similar in these conditions in group 1. And I did point out that this is a very small, relatively small population of patients if you look at the whole pie of pulmonary hypertension compared to, for instance, left heart disease. Idiopathic pulmonary hypertension, pulmonary arterial hypertension is more common in women and usually diagnosed at about age 35, 37. I think what is instructive as we go over the discussion of pulmonary hypertension is to realize that of all we currently have in this arena, the key problem is that the diagnosis is always made too late. And part of that whole process is the physiology of the pulmonary vascular bed. That pressures do not really go high until you've had considerable impact in terms of changes in the pulmonary vascular bed. So you can, by the time you're seeing elevated pressure, there has been considerable remodeling of the vessel already in progress by the time you see the pressures going on. So these are, in the familial case, it's about 6 to 10% of PAH patients have familial, and it's, like I stated, there is a genetic predisposition to that, which is autosomal dominant inheritance. Of course, systemic sclerosis or connective tissue disorders are associated with with pulmonary arterial hypertension, drugs, portal hypertension, and sickle cell disease. The control of the pulmonary vascular bed is mediated by these 3 systems. These are the main systems that have been fully elucidated as part of the underlying pathophysiology in terms of the control of the pulmonary vascular bed. There are areas of interest or research going on looking at other potential targets in terms of the pulmonary vascular bed, including things like tyrosine kinase or Rho kinase. All those areas are areas of ongoing research. But suffice to say, the prostacyclin pathway mediates dilatation through the cyclic AMP system, and it also has anti-proliferative effect on the vascular bed. The nitric oxide pathway mediated through L-arginine and the effect of nitric oxide synthase has an effect mediated through the signaling effect, is mediated through cyclic GMP, and the end result is also the vasodilatation and anti-proliferative effect. Whereas the endothelin pathway mediates vasoconstrictive proliferation, tissue proliferation. So this is the balance, the vasoconstrictive and the vasodilative forces that are operating in the pulmonary vascular bed. And this is where the target of therapy has been focused. In terms of pulmonary arterial hypertension, which is a separate group, the group 1, which has been well studied, part of the underpinning in terms of the pathology is a vasculopathy of the small pulmonary arteries with cellular proliferation. The balance between cellular proliferation and apoptosis is tipped in favor of proliferative forces, and that is part of the remodeling that occurs at the pulmonary vascular bed. There's excessive vasoconstriction, and if you look at the tissue section of the vessel, there is profound intimal hyperplasia with medial hypertrophy and adventitial proliferation, and with superimposed thrombosis in situ. This is the classic plexiform angioproliferative arteriopathy that has been discussed in the literature. What are the clinical findings? Pulmonary hypertension. We are familiar with all of these findings: dyspnea, fatigue, chest pain, syncope. When this occurs, in terms of the WHO functional classification, it automatically puts the patient as a class 4, which is the worst prognosis. So any patient with pulmonary hypertension who presents with syncope goes directly to class 4. It doesn't matter what their pressures are. Question. we thought we were going to have questions in all of this, just to redirect and have people focus. Which of the following may account for the production of anginal symptoms in patients with PAH? With PAH. A. Elevated right ventricular myocardial oxygen demand due to high wall stress. Decreased systolic blood flow in the coronary branches to the right ventricle. Compression of the left main coronary artery by the dilated central pulmonary artery. All of the above. And E, none of the above. So what do we think? And they've given you some, they have an angiogram there, which is a pointer. So let's keep going on. We'll see the answer. So just keep that in mind. You see the angiogram? This is the left main. This is the catheter. We're injecting into the left main coronary artery, bifurcates into the left anterior descending and circumflex system. You can look at the lumen. You can look at the diameter here and the diameter there. They are different, right? So there's some compressive force. Okay, so let's keep going over the clinical findings. So you might have right ventricular lift, which is indicative of an overworking right ventricle, increase in jugular pressure with an early A wave, hepatomegaly and the pulsatile liver. This is all evidence of a congestive effect of a dysfunctional right ventricle, which is bearing the impact of what's going on in the pulmonary vascular bed. Loud P2, indicative of the severe elevated pulmonary arterial pressure. Right-sided S3, S4, I always tell folks around, S3 and S4 is not a monopoly of the left side. You can also hear those sounds on the right side. It's exactly the same underlying physiology. And then you might have a holosystolic murmur indicative of tricuspid regurgitation. All these are evidence of right ventricular dysfunction. These are also additional findings you might have in patients, particularly based on the type of underlying etiology leading to the pulmonary arterial hypertension. So, in terms of the clinical evaluation, here is the chest X-ray, which is always important, and you can delineate some salient findings. Prominent central pulmonary artery will be helpful with the peripheral hypovascularity in the lung field. Evidence of right ventricular enlargement, the lateral chest X-ray film is where you want to go for that. We see the reduction of the retrosternal space. In terms of the electrocardiogram, evidence of right heart strain or right atrial enlargement or right axis deviation, as you see there. And of course, a P wave here being prominent is also very helpful to indicate what's going on the right side. And of course, in the right patient, there's a reduction in diffusion capacity. So all these are things you want to look into as you evaluate those patients. So this is another question, and we'll come across the answer as we go on. Now, the following are predictors of poor prognosis in idiopathic pulmonary arterial hypertension, except, so what they are looking for is the one that is not a prognostic indicator here. This stands for 6-minute walk distance. What we do, this is a form of functional assessment. It's kind of having the patient is not like a treadmill, but it gives you the average functional capacity of the patient, kind of something that will be similar to when you kind of assess the NYHA class in patient. So you have a patient walk back and forth through a distance of 100 meters, and you see how much of that distance they cover in 6 minutes. Usually, if it's less than 300 meters in 6 minutes, it's bad sign. And changes of greater than 50 meters markers of improvement in terms of patients that you've started on therapy. Okay, presence of pericardial effusion, right atrial pressure greater than 20, pulmonary artery systolic pressure greater than 100, WHO class 4 symptoms. So who can guess? B. Okay. So let's go ahead and not D. What about the pulmonary artery pressure greater than 100? That's really bad, right? That's almost like systemic arterial pressure. The right answer is D. Pulmonary arterial systolic pressure is good up to a point, and I will show that to you. Predictors, these are all the predictors that have been well established. At the time the patient has pericardial effusion, it's a real marker of bad outcome. Severe, and it indicates severe RV dysfunction. 6-minute walk distance, I said it's less than 300 meters, it's not good. RV pressure greater than 20 is indicative of high filling pressure and dysfunction of the right side of the heart. And WHO class 4 symptoms, and you can include syncope in there. That's bad. IBMP or N-terminal proBNP. These are all markers of the hemodynamic load due to the underlying condition. So this is the answer about the blood pressure. So let me go by this carefully. Now, this is cardiac output, pulmonary artery pressure, pulmonary vascular resistance, right atrial pressure. This is time, and this is the progression of PAH. As the disease starts in the pre-symptomatic compensated state, pulmonary artery pressure rises, pulmonary vascular resistance rises, symptoms progressively get worse. Cardiac output is maintained. When decompensation occurs or when the patients become symptomatic, vascular resistance is still going up. Cardiac output starts its decline. Pulmonary artery pressure is still going up for the most part, and symptoms are getting worse. Right atrial pressure, which initially was well maintained at its baseline, starts creeping up. In the declining stage, where the whole process is accelerated, here's what you see. The vascular resistance continues to go up, but it has come to a point that the pressure is, the right ventricle is unable to maintain that pressure to overcome the resistance, and so the pressure actually starts dropping. So it depends on where you see this patient. If you see this patient with the pressure coming down and you say, oh, the pressure is not that high, it doesn't explain what's going on with the patient, then you've missed the boat, because this is a declining portion of the curve, and this patient is in a lot of trouble. So the pulmonary artery systolic pressure is not a predictor of outcome or bad prognosis because of this. And in terms of the natural history, if you look at a bunch of underlying causes of pulmonary arterial hypertension in terms of survival, patients with HIV disease as the underlying etiology for their PAH do not do well compared to, for instance, patients with congenital heart disease. So in terms of the evaluation, we've mentioned a lot of this, so I wouldn't be spending too much time, but just to focus on a few areas, particularly in the echocardiography aspect. We've talked about chest x-ray, EKG, and the role of that, and that helps you to start screening folks who might have pulmonary hypertension. In terms of echocardiography, we talked about the number. RV systolic pressure greater than 40 warrants you to do something more for the patient in terms of really defining whether this patient has pulmonary arterial hypertension or pulmonary hypertension, and that usually involves looking at the echocardiography, the RV morphology, and the size and the function. And it's important that echocardiography can be very limited in terms of the quality of the image you get for this kind of patients, you might not be able to delineate or define the right ventricular function accurately. And so that's the problem that we have with echocardiography. But in cases you can, if the RV function is normal, that's a good sign. There are some additional tools that are coming up in terms of potential use in patients with atrial pulmonary hypertension. What we call the TAPSI, the tricuspid annular plane systolic excursion, is now being used to determine if it's greater than 16 millimeters. It means that the right ventricular systolic function is fine. This is just the vertical motion of the tricuspid annular plane. The other thing that is coming out, and this was something that is being proposed by Pathophysiology from Pennsylvania, is the notch, the pulmonary. If you look at the right ventricular outflow envelope or the velocity, and if there is a notch, like you see the dichrotic notch on the aortic waveform, it indicates that that elevated pulmonary artery pressure is as a result of a pulmonary vascular bed disease. And if you combine that with the TAPSI, you're able to predict who is going to do well in terms of prognosis. So that's something in undergoing clinical evaluation. Of course, tissue Doppler. But I think the most exciting thing is the role of cardiac MRI. Cardiac MRI gives you beautiful pictures of the heart with great details, and I think that potentially might be the way to go in some of these patients. Echocardiography is an important screening tool. Part of the challenges with echocardiography is that we may not get a good tricuspid regurgitant jet for us to determine the pulmonary artery pressure. We get the pressure on echo from a good jet. If you don't have a good jet, you can't really tell whether there is an elevated pressure. Or sometimes you see a jet, but it's not a complete envelope, and you're unable to make a sense out of it, even though that patient might have, pulmonary hypertension. But there is quite a number of information you can get, which I've already alluded to, and beyond that, the patient should go to right heart catheterization. This is the envelope I was talking about. We want to see a nice uniform jet looking at the velocities across the tricuspid valve. That's what you need. That's what you want, a neat, clean envelope. And using the modified Bernoulli equation, we can estimate the pulmonary arterial pressure under one condition, in the absence of pulmonic valve stenosis. So if you take this big jet, that's 3, you square this 9, and you multiply it by 4, that gives you the pressure gradient across the tricuspid valve. And you add that to an estimated right atrial pressure, and that will give you your RV systolic pressure, which is equivalent to your pulmonary artery systolic pressure, instantaneous pressure, in the absence of pulmonic valve stenosis. So this is what we do in the lab. So quickly, the other investigation, VQ scan to address chronic thromboembolic pulmonary hypertension. It is important to know that the tests that you angiograms do not detect chronic PE as well as VQ scans. So we don't rely on PA grams. And very low probability VQ scans tend to exclude the thromboembolic form of pulmonary hypertension. And high probability VQ scan in those instances, they say warrant pulmonary angiography, but it doesn't necessarily mean you have to go through that. Typically, we take these patients to the cath lab and we get the accurate pressures. So, VQ scan will be the preferred test. The other tests include, these are the things you got to go through in order to declare that you appropriately classify the patients, and that determines or informs the therapeutic options. Sleep study is also required. Another question. A 73-year-old man with hypertension and diabetes and idiopathic pulmonary fibrosis has a normal ejection fraction and pulmonary hypertension at echo. He undergoes a right heart catheterization, and these are the pressures. So I'm going to walk through. So mean right heart pressure is 15. That's elevated. The He has pulmonary hypertension, we know that. Pressures are high. We said the cutoff was 40, or mean of 25. Mean wedge pressure is high, okay? And wedge sat is 89%, which is pretty close to systemic arterial sat. Cardiac output is 5 liters. Which of the following is the most likely cause of the elevated right ventricular and pulmonary arterial systolic pressure? Idiopathic pulmonary arterial hypertension, hypoxic pulmonary vasoconstriction, diastolic heart failure, pulmonary vascular disease due to idiopathic PF, pulmonary veno-occlusive disease. Some said C, diastolic heart failure. So what do you want to do in order to reach that conclusion? You want to calculate what? The PVR. You got to look at the pulmonary vascular resistance. All right? Whether it is normal or whether it is low. If it is normal, it cannot be PH. What else tells you? What else is very informative? The wedge pressure is high. Okay, the wedge pressure that is high makes PH unlikely as the cause of the pulmonary hypertension. So the PVR we calculate, as I stated earlier, mean arterial pulmonary arterial pressure minus the mean wedge pressure, 35 minus 25, which is 2, divided by the cardiac output. So it's less than 3, right? So it cannot be PAH, right? So that's most likely your diastolic heart failure causing those pressures. All right? So the treatment will be to treat the heart failure. So this is an important point because there are a whole host of middle-aged women or older women who present with dyspnea. Because they do an echo and they have a normal LV systolic function, we really sometimes don't even drill down more to figure out what's going on. So there are a whole group of patients with diastolic heart failure who present in this form, particularly in women. So in terms of the other causes, lung conditions that may cause elevation in pressures, what we see is that they never cause such profound elevation in pressures as we saw in those numbers. They never get up to 70. So the pressures may be high, but they're usually, mild or moderate. They're never severe PH in patients with underlying, lung disease. So that's one way of, something you should pay attention to. So there are a host of other serological tests you need to have, to address all these other conditions that we stated earlier in terms of the clinical classification. And of course, we want to do a functional assessment markers at the baseline to determine the potential prognosis. And then, of course, the patient has to undergo a right heart catheterization with a vasodilation testing, which is very helpful to kind of give us a potential assessment of what kind of therapy might be appropriate initially, or if there is an underlying cardiac cause of the dysfunction. So there are patients that you might take to the cath lab and the wedge is fine. So you do the pulmonary capillary wedge, it's still about 14, 13 or 12. The pressures are not that high. The pulmonary vascular resistance is normal, so you don't have a diagnosis yet. What we've realized is that exercising the patient in the cath lab or giving them some form of agent isoproterenol or isopril to increase the heart rate might lead you to uncover an elevation in the wedge pressure, which would be the reason why they are symptomatic. So right heart catheterization is required. No therapy should be started without right heart catheterization. It confirms your pressure, and you can determine all those numbers we talked about. Calculating the pulmonary vascular resistance, it should be less than 3. The cutoff is 3 Wood units, and you got to suspect diastolic heart failure, as I alluded to. You may have to do an exercise on the in the cath lab to uncover diastolic heart failure. All right, so this is another question. Previously athletic 38-year-old female presents with exertional dyspnea and lightheadedness. Echo shows average systolic pressure of 90. Evaluation of lung disease and all these other tests were negative. The right heart cath shows a mean pulmonary artery pressure of 60 and pulmonary capillary wedge pressure of 10, cardiac output of 5. When given IV ibuprofen in the cath lab, the mean pressure decreased to 38. Mean pressure was 60, came down to 38, and the cardiac output increased. The most appropriate initial therapy for this patient: inhaled prostanoid, sildenafil and warfarin, digoxin, diuretics and warfarin, amlodipine and warfarin, intravenous prostanoid and warfarin. You can guess. B. All right. What we do in the cath lab, we do this test we call the vasodilatory test, where we often in grading we use nitric oxide, 40 parts per million or 80 parts per million. There are other ways you can do it. You can do an adenosine drip, or you can do a nitroprusside drip. What you are trying to do is to put the pulmonary vascular bed under stress and see how it responds, whether there is still a potential modifiable change or the capacity of the pulmonary vascular bed to respond to a vasodilatory force. That's what we do and we call it the vasodilatory response. So, here's the definition hemodynamically in the cath lab. If you have a decrease in the mean PAP greater than 10 or equal to 10, it's a positive test. That there is some vasodilatory response. If you decrease the mean pulmonary artery pressure to 40 or less, that's also a response. And cardiac output does not get worse under those two scenarios. And that was what occurred in that patient. The mean PAP went from 60 to 38, which is a response, and the cardiac output actually increased some. It did not decrease. So, when you do this, only a very small percentage of patients with pulmonary arterial hypertension, that's where we do this test. Only a very small number, less than 12%, are responsive. So in some centers, they don't bother to do it. And some of the reason they give is that the percentage of responders is so small, so it's unlikely to be beneficial for the cost of the intervention. Therefore, this informs you in terms of selection of therapy, where you want to go. Now, if you have a vasodilatory response, what clinical research has shown is that these patients do well. They do well, especially if you initiate therapy with a calcium channel blocker at the outset. So, these are patients with initial therapy of a calcium channel blocker for responders only. Treated patients in terms of survival, excellent. Patients who are untreated responders did not do as well. So when you see those response, then you want to make sure that you start the patient off with a calcium channel blocker. And the calcium channel blocker that's been used is either the dihydropyridine, that's the Norvax, the amlodipine, or cadicin, not verapamil. Here is adjunctive therapy, the list of adjunctive therapy you want to initiate. Is there sufficient data to support some of these? They're kind of symptomatic stuff. Digoxin, we just put it in there and hope for the best. And of course, oxygen if the patient is hypoxic. So these tend to help in terms of alleviation of the symptoms, but not definitive therapy. So that young lady, previously athletic lady, the answer is amlodipine and warfarin. So because she was a responder. So that's what you're going to do as initial therapy. Now, if the question were different, and this previously athletic lady had syncope, it changes the whole equation, because that's a WHO class 4, and you got to treat them aggressively with the best agent that you have. All right, there are a whole bunch of studies that have been done. It is important to underscore there are very few survival trials. Many of the trials have been morbidity stuff, people increasing their exercise performance, very little in terms of long-term survival. So there is limitation in terms of what we have in terms of clinical trials based on vascular targeted therapy, and this is particularly applicable to patients with PAH as against the other types. So basically, decrease in symptoms and improvement in functional capacity, improved hemodynamics. These have been the endpoints of many of these. Survival already an endpoint in many of these trials, but that is changing. I think there is now an effort pushing for survival trials as part of the way to approve drugs. And again, where these therapies are targeted is targeting these systems that we talk about. When you talk about the prostanoids, this is augmenting the prostacyclin pathway, which is mediated through cyclic AMP, resulting in vasodilatation. When you talk about phosphate diesterase inhibitors, it's the inhibition of the cyclic GMP breakdown to allow this to cause vasodilatation and anti-proliferative effect. ETA, endothelin A and B receptors, particularly most of the agents have an affiliation more for the A receptor blockade, and that is to prevent the vasoconstricting forces. So that's a brief summary of what the potential impact. So what do they do? Vasodilatation, anti-proliferative, inhibition of platelet aggregation, and in patients with PAH, all this stuff are decreased. The production of prostacyclin is decreased, and therefore you do not have that benefit. Again, these are some benchmark treatments, and basically these are the benefits you want to see with this agent. I'm going to go through some of these. There are different forms. The intravenous form, and I really want to acknowledge the role of Dr. Enriquez Forsyth in making sure by our effort that we now, our patient population now have access to some of these agents. As you can see, this stuff is expensive per year. And our patients cannot, I don't think anyone can afford that. I mean, so that's really a death sentence. And I think when we talk about healthcare outcome disparity and all that stuff, this is the stuff that helps to close that gap. Okay. And there is subcutaneous form and of course in inhaled form. Again, these are the endothelin agents. And these are the benefits you want to, these are the things you want to stop. Antagonize the vasoconstrictive forces, smooth muscle cell proliferation, and the vascular remodeling that is induced by the effect of endothelin. So examples of these are also very expensive drugs. The Busantan, the Teris, this stuff costs a lot of money, even the oral ones. And of course, you got to monitor the patient. There are considerable potential side effects. Of course, with Busantan, some of these side effects are less robust, particularly the hepatotoxicity of Busantan. Nitric oxide pathway, you want to augment that. Of course, there is no, because the nitric oxide gas is very unstable, there is no form of, the marketed form of nitric oxide. Sildenafil, you can use that, and what it does is prevents the breakdown of cyclic GMP by inhibiting phosphodiesterase 5, and that's how you achieve your vasodilatation and anti-proliferative effect. All right, we are all familiar with Rivatio, 20 milligrams TID. All of this stuff, they help to improve symptoms. This is 6-minute walk. There is substantial improvement across the board for all of these agents. So this is an algo reading of PAH. Again, Anticoagulation and diuretics, pretty much almost everyone. If they have vasoreactivity testing, if it's negative, for the low-risk patients, you can start them on oral agents and progress over time to the intravenous agent. If they're high risk, you don't start oral. You go straight to the intravenous approach. Okay? For patients who are positive vasoreactive testing, we talked about oral calcium channel blocker. If they sustain response, you continue. If they stop responding, you switch them to the other agents. Is there a role for combination therapy? We see more of that, combination of sildenafil with many of the other agents, and I'm going to go through this quickly. Balloon atrial septostomy. This is reserved for patients who have significantly low cardiac index, who are presenting with syncope. This is an option. So you're trying to increase flow. There's a downside to it. There is an absolute contraindication to it. If you have significantly low systemic arterial saturation, you don't want to bring more deoxygenated blood into the systemic saturation, systemic circulation. So that would be a contraindication to balloon atrial septostomy. Lung transplantation, last option. There was a young woman on TV recently who had PAH, a singer. I saw on one of the network news who had lung transplant, and she's come back and she's singing at a very, professional level. I just saw that by chance, and I thought that was great. Now, I want to go over an NIH study which I'm participating in, and this is, and I think this was long overdue. And the reason NIH got involved is because nobody would do this study. No drug company are going to do this study. And this is a study to look at the mechanism of disease and the pathophysiology. Some of these studies do not have enough financial investment to support it. And the reason for this is that we know pulmonary venous hypertension is common. This is called the PITCH-HF study. And it looks at not just morbidity, it does look at mortality. And this is looking at the effect of PDH5 inhibitor. This is going to be tadalafil in patient versus placebo in patients with class 2 to 4 heart failure. And the idea is that PD5 inhibitor does not only target the pulmonary vascular bed, but it also targets the myocardium as a potential source of impact. The patient goes the way the right ventricle goes. Once there's right ventricular failure, case closed. There's nothing else, unless you want to do a heart-lung transplant. So, if you can intervene and impact the process in the right ventricle, that's an additional option, in addition to working on the pulmonary vascular bed. So it's an NIH study, 21 years and above, class 2 to 4, patients with EF less than 40, document secondary pulmonary hypertension. These are patients who are relatively stable, with stable medical therapy for at least 3 months prior to randomization. The goal is to randomize over 2,000 patients. An average follow-up is going to be 2.5 years, and I said tadalafil is the agent of choice. Primary outcome, time to cardiovascular death and heart failure hospitalization. There are a bunch of secondary outcomes that we're also looking at. So stay tuned for the PITCH study, which is going to start early next year. Another question. I think I have 2 more questions and then we'll close. 52-year-old man with limited scleroderma presents with class 3 exertional dyspnea, fatigue, and 2 episodes of exertional syncope. The 6-minute walk distance, 280. We said 300 was the cutoff. Mean right atrial pressure, 18. Pulmonary arterial pressure is high, mean 60. Peer pressure falling. Inhaled nitric oxide didn't drop by about 10. Kind of borderline. Mean wedge pressure is normal. Wedge saturation 83%. Cardiac index 1.8. What's the cutoff cardiac index? 2.2, right? So that's low. What is your pulmonary vascular treatment of choice? I think after 1 hour, you guys can tell me this. Intravenous? Why? Okay. I think you are awake. So, there are markers there of bad prognosis in this patient. One is syncope, the other is the distance, and then low cardiac index. So if you put all these three together, this is not a patient you're going to be trying oral agent. They are far gone. So you need to go to an intravenous approach. So the hemodynamics and all the evaluation stuff mean something in terms of decision on therapeutic intervention. All right, final question. 65-year-old male with pulmonary hypertension and right heart failure in the setting of severe COPD. Which therapy best impacts survival? I hear someone saying 4. No? What's the answer? Oxygen still works. Yeah, it's oxygen. Okay? That's where the evidence is. So, do not think everybody needs to have these drugs. They are expensive and they have profound side effects. I think, well, there's one more question. You want one more? Okay, let's do this. Concerning placenta used in treatment of pulmonary arterial hypertension, which of the following is correct? Unlike treprostinil, placenta is relatively safe in pregnancy. They want the correct one, right? It's contraindicated in patients with renal insufficiency. It's a specific antagonist to endothelin B receptor that affects the efficacy of estrogen-based contraceptives. Yeah. I think the answer is 4. Okay, I think that's the end. But I think it's important that we realize that the hemodynamics means something in terms of classifying the patient. You wrongly put a patient in one bucket and deny them life-saving drugs or life-saving treatment, or you misclassify a patient and put a patient who shouldn't be there and commit them to therapy. It has a profound impact, and it's important in terms of the evaluation. Okay, questions?